Hello, welcome to the Center of Excellence for Infant and Early Childhood Mental Health Consultations inaugural conference, Equity from the Start. My name is Sherry Heller, and I will be serving as your session moderator. And I am joined by Anne, who will be serving as our technical host. The session is being recorded and transcription will be available through the Zoom platform. Should you have any questions, feel free to relay your questions in chat. We hope to have time at the end of the session for discussion. And we're asking that when you have a question to ask, you can either put it in the chat or raise your hand with the button at the bottom of the screen, the reaction button. If you click on it, it has a little bar for you to click on raise your hand. If you click that, the moderator will see that and will be able to unmute you when it's your turn to ask your question. And here I go. I'm going to turn it on over to Sandy to share her work with us. Thank you, Sandy.
Thank you. Well, and so good morning. It is a bright and early 8 o'clock here on the West Coast in California, where we are. And so for some of you, you've already had a lot of your day, right? It's midday for you. So thank you for being here today. And I am Sandy Avzaradel. I am the director of Startwell, which is a mental health consultation program for early care and education. And I'm here to present to you some of the research and findings that we have gathered for our program, which started in 2018 here in Orange County, California. How Startwell began, it used to be called the Early Childhood Mental Health and Wellness Program, which was a little bit of a mouthful. So we did rename it Startwell. And a group of our collaborators, which some of them you see there on the poster down at the bottom, the Early Childhood Mental Health collaborative, rather, was a group of concerned community partners, including Chalk Children's Hospital, Children's Home Society of California, the Regional Center of Orange County Department of Education, and Cal State Fullerton was part of it, and then Orange County Association for the Education of Young Children. This group of that we call the Early Childhood Mental Health Collaborative got together in 2015 to address the concerns about expulsion and suspension in preschools, and how we know that that sets children on a trajectory of not belonging in school, where they feel that school is not a safe place for them if they've been asked to leave the program due to challenging behaviors. And so this group really wanted to address that in Orange County and ensure that all children were around responsive adults that understood social and emotional development and would work with them, had the skill set to work with them in their early care and education programs. So I was hired in 2017 to design and implement what is now Startwell. And I used the Georgetown model for school-based infant early childhood mental health consultation. And also the pyramid practices. So the pyramid model practices are what we use to provide to the providers in terms of best practices. And we infuse those best practices into the consultation work we do. We do not, however, scale up a program on the pyramid model, but rather we use the process of the Georgetown process of school-based mental health consultation and interweave the tools and those best practices from the pyramid model into our programming. So when a consultant leaves the program and they have the providers have the tools and resources to be able to do this work all on their own. So we started in March. We implemented in March of 2018. At that time, we had actually 3 part-time infant early childhood mental health consultants. And since that time, we've grown to 6 full-time infant early childhood mental health consultants, which maybe some of them are on this call now. And our dosage, if you will, is the process that we use is anywhere from 3 to 6 months with 1 to 3 hours per week of in-person consultation. And we found that that was our sweet spot in terms of programs, um, having enough momentum to keep going with at least 1 hour a week of consultation. So anything less than that, we found that things stalled, and the energy and the momentum just kind of held back, and it was difficult to move them forward. Anything more than 3 hours a week, we found that our providers started to rely on the consultant to manage things that had happened during that week. It's like, oh, we'll just wait for our consultant to get here to do this. And so we want to empower them. They are the experts of their program, and we hold that consultative stance very tightly in terms of realizing that they are the experts of their program, and we are there to support them so that they can then support their children and families that they serve. So 3 to 6 months was pretty typical. Again, we didn't have a hard stop at any time. It was based on the process and how quickly they could move through the process and get to the place where they could sustain their practices with fidelity. That's our end game. We want to make sure that the providers are confident and competent and that they are sustaining these best practices. Due to COVID, of course, we received a healthcare agency grant right at the very end of February of 2020. And so that's when we really scaled up, and we had 5 full-time consultants. And then COVID hit. So of course, everybody experienced the term of the century, I think, is pivot, right? We all had to kind of pivot and figure out how we were going to do this. What we found is it was fairly easy to transition to online and Zoom. So many of our programs continued to do the work. Of course, some closed. But because of the closures due to exposures and things like that, so they would close and then they'd reopen, we found that, and you'll see in the conclusions, that we found that we were spending an average of 8 months with a program. So we actually are just now kind of closing out some of those programs that we started in the middle of the pandemic, just obviously because of that timing took a lot more time. So typically it is a 3 to 6 month process, 1 to 3 hours per week of support. And to ensure that sustainability and fidelity to the practices, once we've exited out of a program, we come back in person for 3, 6, 12 months, and then yearly thereafter. And in those years, when we're the year mark that we're revisiting these programs, we're looking at their sustainability, transition and sustainability plan, which is part of the process. And we are then at that year mark, we're also doing the benchmarks, early childhood benchmarks of quality again, and we're doing the provider survey again. And that is to just ensure that they're confident and competent, and that helps us to understand what support they need ongoing. We also offer monthly communities of practice for our providers. So as soon as we do that first initiation meeting, they are invited to our communities of practice. And right now we have about 43 programs that we're working in currently. And I would say about 25 programs attend that's an average, attend our communities of practice every month. So really nice participation there. And we go off of what they are needing in terms of presentations and what we do and what we talk about. So we have lots of community resource presentations to ensure that the outside mental health and behavioral health programs, that the providers know that they're out there, and and then just other things that the providers want to scale up on. We will do presentations, and typically we have outside speakers come into those communities of practice and do some training with them. So you can see here our goals there are, and I'm not going to read them to you, you can see them there, but basically we want to ensure that our early care and education providers are using evidence-based practices or research-informed practices, and we want them to promote social emotional development, prevent challenging behaviors, and provide individualized behavior supports for children that demonstrate ongoing challenging behaviors, and then know when, where, and how to refer out. So we also have a direct referral system to CHOC Children's clinical services. And so if the team, once they've worked through that PTRYC, Prevent, Teach, Reinforce for Young Children process, for an individual, if the team feels that this needs something more, more of a clinical assessment, then we will refer to directly to CHOC Children's Hospital. We also have direct referrals to PTIC, and 2 of our consultants are trained on PC Cares. So we will provide PC Cares for those families. The consultant that's working with the school will not be the consultant that delivers the PC Care therapy. We would have another consultant do that. So we have an internal process where we can refer internally for PC Cares as well. We also have a school readiness program through the healthcare agency that does in-home. They use the PPP parenting practices, so we can refer directly to them. Of course, regional center and school districts, we will make sure that there's a warm handoff there. But again, we're coming from that consultative stance where we are not the experts, but we want to make sure that the providers know, again, where, when, and how to refer out. So we make sure that we're doing this alongside them, having that warm handoff. So the director of the program knows who to contact at a school district, and we'll work alongside them for that. We want to make sure that the adults, all those dyads, have very strong and responsive relationships. So adults and adults, adults and children, families and the staff, all of those different dyads are critical to have that positive and responsive relationship. And so that is one of our goals. And then helping providers communicate with their families the importance of social and emotional development, and how we can engage our families in providing those supports for their children to promote that social competency and emotional development that we need. And that, again, the systems are aligned. So our outside community support systems are aligned with the early care and education provider system, and everybody can access it in a fluid, easy manner. So those are our goals. You can see there are objectives. So these objectives are what drove our evaluation process, and we created our internal evaluation process. So it's really a 2-layered one. One is internal program evaluation. So start well, are we doing what we set out to do, and how can we improve that? So we developed the tools you'll see there on the poster. There's a director initiation or intake. And I'm just going to go through the ones that we developed. So director initiation and intake, the teacher, we have a pre and post survey. The director has a pre and post survey, and then the parents have a post survey. The referral logs, the consultation logs, all of those are evaluation data that we created internally. And then we, of course, we use the benchmarks of quality for every program. All of that is what we use to determine if Startwell is doing what it set out to do. The next level of I guess you would call it evaluation, is the programs themselves. So they used, of course, they use the benchmarks of quality to look at their own program. And then all of the other tools that we use, like I said prior, if we use the teapot or the tippy toes, or the pyramid model checklist, all of those are tools for the early care and education providers program improvement. And so we don't keep that data, the program's data, on their own program improvement, but rather we use that process of Georgetown, that model, the Georgetown model, to help them improve their programming. And so what you see here is looking at those objectives I have on the left-hand side, and the results there is are we doing what we set out to do? And this is based on just 65 programs right now that have actually completed the process, and we have the matched pre and post data for. So if you can see down at the bottom, the blue line is before we started the intervention or the consultation, and then the green line is after. And so the first one is the percentage of children displaying appropriate emotional development. So before we started, it was below 60%, and after we started, it was at 70%. So one of the questions we do in the initiation and intake is we ask the providers to tell us what percentage of your children are at age level, typical age level for social development, and then separately for emotional. So we have at age, above age level, below, and it's really their interpretation of it. We talk about the difference between social skills and emotional development, but we ask them to rate their students overall, and that's where we can come up with those numbers. So then the next one over is the social development. So again, they were right at 60% and just right below 70% after our work with them. This is my favorite statistic. About 25% of providers said that they are likely to remove a child. We asked them the question, how likely are you to remove a child within the next 6 months? And they respond to that. And so here you have 25% of programs saying that we're likely to remove a child from care permanently, down to less than 10%. So that to me is the biggest indicator that we're doing what we need to do. And then on the right hand side, again, same coloring, is the blue is before and the green is after. And we ask them on a Likert scale, 1 being poor and 5 being excellent, the staff's ability to respond to children with challenging behavior. And you can see there that they rate themselves as a 3, so right in the middle of the scale. And then after our support, they were above a 3.5, so I think it was 3.67 or something. So we are increasing the staff's ability to respond to children with challenging behaviors. And then the next one was the staff's ability to implement best practices in preventing challenging behavior. And they were at like a 2.7, and then went above a 3.5, so around 3.6 again. So really good results. Our conclusions are that you can see there, I just did some data widget counting about how long we've spent, an average of 1 hour and 20 minutes per week with 33 interactions per site. So if you look at each of the sites, they averaged 33 interactions with the consultant. And those could be anywhere from 1 to 3 hours. And you see our average is 1 hour and 20 minutes per week with each site. And then our length of time, like I said before, was 8 months on average. And we've made 72 referrals to outside agencies and facilitated 36 individualized behavior support plans using the PTRYC method. Children in the care of adults who worked with a Startwell consultant increased in their social emotional development, with less children displaying ongoing, permanent, or persistent challenging behaviors. And they're much more likely to, or less likely to remove a child from their care. We're finding that sites said their experiences were positive and effective and are likely to recommend the program. So I wanted to just explain too that we provide services for non-state or federally funded programs. So family child care homes, center-based homes, and we are also expanding to expanded learning programs as well. We just started that this past fiscal year, where we're supporting school districts that have that before and after school care, or private programs like the YMCA, Boys and Girls Clubs, those types of things. So, but we are prioritizing programs that don't have support from state funding and don't have the process that happens in our Head Start programs. We're working with all of the other programs that don't have access to those funds for infant early childhood mental health consultation. So we, to date, we've been in 119 programs throughout Orange County. You can see there our collaborative. I'd like to very much acknowledge the collaborative who was the brain behind starting this program, and of course Chalk Children's. We use Chalk Children's funds through philanthropy dollars. They have quite a great following of people, family foundations that are really interested in infant early childhood mental health consultation, as well as grants that Chalk applies for. We also are recipients of some of those funds as well. And then of course, Orange County Healthcare Agency, we, through MHSA dollars, Prop 63 was a proposition passed here in California that takes a percentage of taxes and puts it into mental health services. And we are prevention and intervention recipients of those prevention and intervention funds. And then Charitable Ventures is our fiscal agent. So we don't hold our own nonprofit status. We work underneath Charitable Ventures. So that is who I'd like to acknowledge. Any questions?
Thank you. Thank you. That's a lot of information that you shared.
It's a lot.
I did put in the chat a link to the poster if people want to download it so that they can kind of read it. It's kind of hard to see on the Zoom screen.
Yes.
So download it from the, if you go to the conference website and the poster sessions, you can download it there too.
Great.
If folks have any questions, they can put it in the chat, or you can just raise your response hand. Any questions or comments that you'd like to share? I was interested in your expansion when you expanded into the different programs. And did you find any differences, or did you have to shift any of kind of how you do your work when you went from centers to family child care? Or
the family child care in the centers, of course, the pyramid model has wonderful tools for family child care as well. So that was a pretty easy transition. Of course, it looks a little different. One difference is we get consent to share information from parents for all children in a family child care program, whereas if we're working in a center, it's a passive consent, unless we're working with an individual child. But because family child care centers are so, there's so few children, you can't possibly go in and do any observation without individualizing that. So that's one of the things. But when we expanded to before and after school care or expanded learning programs, that's where we had to really look at how we implemented. So we still go through the same process, but how it looks is very different. Most of these expanded learning programs are very, very large. So they have hundreds of before and after school programs. And so we've done we're doing more of a trainer of trainers model of infant early childhood consultation, where we are scaling up some of their key leadership in being able to promote these practices. So it's a little much more of that, as opposed to trying to go into each individual program and work with each individual program. We're doing it on a trainer of trainer models.
Oh, that's,
So,
that's yeah, those are big programs.
yeah.
Do you, if it's once a center goes through the 8 months or whatnot, are they able to repeat it down the road, or?
Well, so that, that's an interesting question, because the first time we did have somebody come back to us, my first reaction was, oh no, we didn't, they weren't sustainable. They didn't, that's an us problem, but what we realized is that, of course, because of staff turnover and things, but we account for that in our process, that if one key person leaves, will these practices be able to be sustained? And that's really something we work on. But where we found it was after COVID, that they came to us after COVID, and we realized that just shook everybody to their core. And and so we will come back, but what we have found is they just got a little nervous. But when we went back to really work with them, they had it. They had the practices. It was kind of like a, come hold my hand for a bit, just because, COVID just upended everything in the early care and education world. And they were tired. And so they just wanted somebody else to come in and say, am I really seeing the behaviors that I'm seeing right now? Because the behaviors are so much more intense than what we saw to pre-COVID. And so it doesn't take a whole lot if we come back and do another program to kind of shore them up again. It's definitely not the 3 to 6 month process at all.
Yeah.
We did have that come up. The other thing we did with COVID is, because we kind of look at Startwell as a tier 3 intervention, right? We created what we call a multi-tiered system of support for our providers, where if they, during COVID time, because a lot of them didn't have the capacity to have us out there working alongside them, because they were just trying to survive, right? Directors were in ratio, and all of the issues that we found. So we could support them just with just, hey, would you like us to help you write a parent newsletter? What we kind of call a soft touch, 1 or 2 interactions. We can do that, even if you don't sign up for the whole, process. Or tier 2 support, where maybe we're coming in, doing some observations and working with them on a little bit more intensive, 5 times, versus then, the third tier being the full implementation of this consultation process. So we did do that during COVID as well. Just to support our community, our early care and education community, because they were, struggling so much.
Yeah. I'm just seeing that somebody's having problems getting to the link. If you go to the conference website and you go to the tab that has posters, and you click on the poster tab, all the posters are in there. Okay, great. And I'm watching our time. Thank you, Sandy. This was really informative. We are having a hard stop because right at 10:30, our plenary starting with Chantel Meeks. So I hope that you all can shoot over there to go see that. The advantage to doing this virtually is it just takes us a minute to do that. And thank you very much, Sandy, for sharing your information.
Thank you. Thank you for having me.
Take care, folks.